This is a study that mainly looking the addition of quizartinib to the azacitidine or hypomethylating agent for patients mainly with MDS, MDS and MPN or CML that have FLT3 or CBL mutation. Again, azacitidine as a hypomethylating agent is the standard of care for treatment for these mainly intermediate or high-risk patients, Myelodysplastic syndrome or CML. But on the other hand, this treatment is not ideal for these patients, mainly as a single agent, with a response rate mainly low, as about 20%. And even the responders from this treatment mainly will eventually lose their response in a few months. On the other hand, FLT3 mutation, it is rare in the MDS. It's like 1% of the MDS at the first presentation, and it is about up to 19% in patients with HMA failure. CBL mutation, on the other hand, is observed about 10% of the MDS patient and around 13 to 15 in patients with CMML. And the preclinical data show that CBL mutated cells are dependent on the FLT3 signaling pathway. And both these mutations are associated with worse prognosis in these patients. So in order to assess the efficacy of the FLT3 inhibitors in this context, we conducted a phase 1, phase 2 study of azacitidine in combination with a quizartinib for patients with HMA or hypomethylating agent naive or failure for MDS or MDS MPN with FLT3 and CBL mutations. Mainly, I will be presenting the part of the phase 1 of this study, which is the dose escalation. We have made it almost to the third level, which is the last level of dose escalation, which is 60 milligrams of quizartinib. Mainly fit adult patient with newly diagnosed intermediate or high-risk MDS, CML with a FLT3 or CBL mutation were included in this study. The main exclusion criteria mainly was cardiac arrhythmia and long QTc, as it is the only known cardiac toxicity of the quizartinib. So the main objective of this phase 1 study is mainly safety and tolerability of the medication or the combination. And we found that this combination is very well tolerated with acceptable toxicity and no early mortality. However, as expected, there was quite myelosuppression in these patients that required the dose reduction of both the azacitidine and the quizartinib in about 20% of patients with in quizartinib and about 30 patients requiring dose reduction of azacitidine. And all of this reduction mainly was from cycle 3 and subsequent cycles. Important thing, no cardiac toxicity or any dose-limiting toxicity were occurred in this phase 1 study. In terms of efficacy, we are seeing like response rate about 90% of patients of the cohort having response. Most of these responses were bone marrow complete remission. So in other words, that this regimen is good at lowering the blast in the bone marrow, but on the other side, not all patients will recover their blood counts to consider them as a complete remission. And fortunately, about half patient or 40% of these patients proceeded to allogeneic stem cell as different treatment for MDS or CML. So this is mainly about the phase 1 study, active combination with accepted toxicity. We are continuing now to the phase 2, which is a dose expansion, and planning to recruit 40 patients, mainly 20 patients in the front line, in the hypomethylating naive patient, and 20 patients in the HMA family.